we're back from our trip to Vancouver Island, and we were at a addiction conference. We did an episode about that, but some news followed us from the West Coast about a group that we've covered before in one of our previous episodes, which I'll put up here now. On it's not really there. On a group called DULF, which stands for...
I think the Drug User Liberation Front, but I'm not sure.
Yeah, see? I mean, look at Whip. He's getting his activist credentials in place here.
I will never have activist enough credentials.
All right.
You can't, yeah.
So in the news, unfortunately, the folks that were running this thing were arrested this week.
While DULF's actions were intended to reduce the harms caused by the toxic, illicit drug supply, we have always warned that anyone who violates the Criminal Code or the Controlled Drugs and Substances Act should expect to face enforcement and criminal charges.
On Wednesday, Vancouver police officers raided the offices of the Drug User Liberation Front, or DULF, a community-based advocacy group in the downtown east side. At a press conference Thursday morning, VPD Inspector Phil Hurd said they executed multiple search warrants, going to 2 homes and arresting 2 people.
DULF was the only organization that took it in their own hands to procure and distribute a clean supply of drugs, as we see the toxins and the poisons in the current street supply get worse every day.
DULF has said it bought drugs off the dark web, tested them, and gave them to a group of 52 people as part of a study, with its early findings suggesting members used drugs less and had a reduced risk of overdose. Drug policy analyst Karen Ward says losing the group will hurt the people it served.
I'm very concerned about the folks that are involved in it, because they're not going to know what are they going to do? What are they going to do now? Where are they going to find some other source? It's not going to, they're going to be in a very, their tolerance is going to be different. That makes them very, very susceptible to overdose risk.
The police raids come after DULF's funding was questioned by BC United last month, and on Thursday, MLA Eleanor Sturko called for an audit of how the government funds organizations like DULF.
And this government supported DULF to the tune of $200,000, putting that money potentially into the hands of murderers.
DULF ran its program for over a year, with $200,000 from Vancouver Coastal Health and program support from the BC Centre on Substance Use, though its founders have said that money largely funded drug checking services, training, and harm reduction equipment.
Once government became aware that of the situation, the contract was immediately cancelled. Their contract was for drug testing, not for the purchase of illicit drugs.
Ward says she believes similar projects will fill the hole left behind someday.
What DULF is showing us is that there's something in the future that we can build towards, and that this is a model that actually should fall in any community, in every sub-community. This is something that we can do. It's possible to live beyond prohibition. We can imagine what that future looks like, and that's thanks to DULF.
The VPD says the 2 people who were arrested have been released, but may face drug trafficking charges. In Vancouver, Keir Juneau, City News.
It's almost like the constable was saying, almost like no one's above the law, right? Mm-hmm. But really, this is a very different situation than typical people who may not be following the law, right? So I don't know. I think we talked about it. I think at the end of it, we were all. I don't want to put words in your mouth, but I think we were both in support of the initiative. We were in support of the evaluation structure, and the results. They shared the results online, and I'm not sure what this BC United is. I should know this. I don't know much about politics. I don't know if BC United is like a political party in BC. I should know this, but.
Can't answer that. I don't know.
Yeah, I don't know either. But so they're attributing it to that coming out. But I wonder, because the timing really fits with the results being shared, right? So they share the results for their clients, the overdose rate, self-reported use, report trafficking, stuff like that. And when we went over, we didn't do it online, but I went over before we talked about it on their evaluation framework. And it's very comparable. It's actually probably more thorough than some of the evals I've seen for some of the SafeR supply programs, just given the breadth of reporting. They're really trying to capture what the impact was for these people and for the people around them for it as well. So I'm not sure. It sounds like they weren't charged. I thought they were charged with something. It sounds like they may be charged. It sounds like it was a bit of a political thing in terms of picking them and taking it away. Also, maybe the government looked bad. They're like, hey, we're funding this organization, and they're giving out these drugs, right? So I don't know. I don't know what happened there with it. But the overall news message seems positive, right? The message in the news report was like, this is an essential service. It's absolutely needed. Now we have data, and this should spread to every community and should be available in every community so everyone can have access to it.
Is that what you think?
Well, that's what the person at the end said. No, I don't think so. I don't think it should be available everywhere and every kind of thing. I think they were giving it away for free. They selected 52 people, so maybe from what I read about,
I think maybe the study was based on 52 people. I'm not sure that I'm certain that they have provided.
people that aren't in the study. You think they're providing for people that aren't being captured in the study?
They have definitely provided substances for more than 52 individuals at one point. Yeah.
Okay.
I know that.
Okay, so I didn't know that.
I don't know if the study is limited. I haven't read the study, so.
I haven't read the study either. I just saw the infographics on Twitter, but I would assume they would be capturing all the people that they were distributing the drugs to.
Well, I don't think they know who the people they distributed drugs to. They don't. It's not like.
So you think they just took a sample, like select sample of people that filled out the forms?
Well, I would think people would. I think there's two parts. I mean, they've been going on for a long time. I have
to
please
read the
correct me if
paper.
I'm wrong here. We're both kind of like
ignorant.
We're flying blind on this.
Yeah, we're both ignorant. We're talking about this.
But yes, they've been around. DULF's been around for a few years now, and I would think that the people that they focused on the study would also agree to be part of a study. I don't think they've only helped people. The study was a later thing. I think that they
so they started the program. The study was done. The study design was done later on.
That's what I understand. Yeah.
So I've got to go through this stuff in a little bit more detail. I don't think you can ever justify to going into a place where they have no access to illicit substances and just having all these substances available for free. Whoever chooses to come and get it, I do think you can justify it in certain areas where people are dying from unpredictable substances. I think you can argue for drug testing. When people know it and bring it in, to know what's in the system. But to have an unlimited supply of whatever drug that somebody wants, but I don't think they had an unlimited supply. I think they probably had
no, it wasn't an unlimited supply. Yeah. They had a certain amount, but I think moving beyond DULF a little bit. I mean, you have to look at I think this is part of the bigger question is that do drugs that don't have toxins in them cause any harm?
Well, they cause tons of harm.
They cause tons of harm, and I think that is I think that message has been missed a lot by people, and I think that it's not just the fentanyl that's killing people, and what makes it more complicated is fentanyl is killing people too, but the population of people that do drugs are also looking for the fentanyl, so this gets very complicated. So the drug testing, sure, drug test all you want. But if they're looking for the thing that is killing them, what do you do then?
Well, I think there's value in knowing what you're taking, and there's value in knowing the concentrations and the percentages. Like if you're using cannabis or alcohol, it's good to know if it's a 4% drink or if it's a 50% drink.
Right, but a lot of drug testing, and I'm not saying about their program in specific, but a lot of drug testing is a binary result, right? Yes, there's fentanyl. Yes, there's benzene.
Oh, they don't do concentrations?
Some testing does, but that testing I believe is a little bit more involved. Again, correct anybody if in the comments. But most of the drug testing that I've seen is not concentration; it's just a presence.
Yeah, I guess it would test for illicit substances in there too, right? Like metalizine or xylazine or tranq.
And then what? Well, I guess in their supply they wouldn't sell it. So in that scenario, they wouldn't provide it. But drug testing just generally of people knowing, there's a xylazine and you're going to do it? Yeah, I'm going to do it.
But I mean, maybe they'll be a bit more careful. Maybe they won't. I don't know. I can read people.
Or maybe they'll, in the case of fentanyl, they'll be looking for, even if there was a concentration. I mean, I'm not trying to be a wet blanket on this. I'm just saying this is a more complicated problem than it would appear because it's, if folks are looking for fentanyl and then, I don't think a higher concentration. Sure, more information is better.
Yeah,
truth in packaging on anything.
I think I just have to check my biases a little bit, and I think one of my biases is that I don't feel skilled or competent to give people drugs that they will use for recreational purposes, and I don't feel confident giving those drugs with the goal of it preventing them dying from a different drug, so to speak. So I'll give you an example, right? Say for example, if it was like an alcohol program, I don't feel skilled enough. I mean, I could find a managed alcohol protocol. I could follow it to the T, and I could have it like every hour, every 2 hours, whatever that is. But I don't have the ability to predict when someone's going to have that and it's going to be enough, or someone's going to have that, then they're going to drink on top of it, right? They're going to have the full thing of vodka. They're going to have whatever the sherry or whatever the concoction that's available, and yeah, part of me is that even with the medical cannabis, I'm not sure it should be in doctors' hands. I don't think it should be in a doctor's hands to prescribe your thing, except maybe in harm reduction purposes, maybe in purposes where someone needs to get medical care and they're in a facility they can't have access otherwise. Maybe there's some rigid rules and stuff there. I just don't feel competent enough to prescribe alcohol, especially given that a lot of people I work with don't always take medications as they're prescribed.
No, absolutely.
Right. And so I think for me, part of the appeal to this is to take it outside of the hands of physicians and let people that are better equipped to determine the impact on the individual, impact on the society, like public health, figure that stuff out. I can figure stuff out maybe for the person in front of me if they keep coming back in to some degree, but I can't predict the impact on those around them,
Right.
or the
and I think, sorry, yeah. Go ahead.
Yeah, no, I just don't know. It's like if I was, I don't want to use the wrong metaphor here, but it's like if I was prescribing unhealthy food for somebody with diabetes, right?
Sure.
I don't know if it's better to get them in a mindset where I need to be healthy and not have access, or, is once a week okay to have a certain amount, and, I don't have the right metaphor for this, but I don't think they should have been charged. It sounds like they weren't charged. Right, yet, based on the news report, and I didn't understand the whole reason why it was in the news now compared to like a month ago or 3 months ago or 6 months ago.
You don't understand.
Yeah, well, they've been doing it for over a year now.
Yeah, they've been doing it for.
So maybe it's just the results came out and the result looked positive.
I wouldn't. I don't know. I don't want to speculate on that. But I will say it's not like beyond them to focus on this area. They did just arrest a gentleman. I think his name is George. I'll maybe put it on the screen what it is, but a link to his story will be in there. But there was a gentleman that opened actually a retail store in Vancouver.
Yeah.
And he was arrested.
I mean, he did it as an individual, right? He did it as an individual.
Yep.
Opened up the store. This is something where it's a part of a group. Publish it at some point.
It's not been published.
I don't know. I mean, I saw an infographic. I don't know if it's in a journal yet.
Oh, okay. I don't know. No, I thought you had the report. I thought you did a full report on the report, and that's what you're coming to talk to us about today.
No, I didn't. I'm not as knowledgeable. And
maybe our research assistant can do that for us.
Who was that? Me? Am I the research assistant?
I don't know who that is. I don't.
All I know is I looked at a couple of the infographics on it. I scanned through their document. It was on their Twitter page, and it sounded reasonable, right? It didn't sound so out there.
Yeah, I mean, it's just a really tricky, complicated problem. That's kind of my point of it, and I just don't think there is a simple solution. For any of it, really, right? And that's why it's problematic. And also, I mean, I'm not a prescriber, but I have many friends that are, and many colleagues that are, and just in full disclosure to people, it has to do a little bit about risk aversion too. So, and again, I'm not wanting to speak for anybody else, but I can fairly say that you're pretty, you're not a very, what would I say? Risk doesn't completely terrify you. Will that make you a
Well, I think the thing that I think about is what's the risk of giving this drug, and I also think about what's the risk of not giving this drug.
Well, I'm talking about risk in another perspective. I'm talking about risk of losing your ability to do your trade, right? So if you lost your license because you made a script that people can lose their licenses for doing this.
Yeah, I mean, I think the thing is, it's like there was this football player, football coach. I forget which team it was, Nebraska, Florida, I don't know which one. And he was like, if the speed limit is 60 and you get a ticket at 65, he'd always go at 64. And for me, I always think about what's the rationale, for providing this. Is it for pain relief? Is it for, harm reduction? Is there a guidance document that covers it? You're right that I'm less risk averse than some of my colleagues. At the same time, I make sure there's a sound rationale or a guidance document that would recommend what I'm doing to some level, and I'd also consult with colleagues on it as well.
Sure. But also we're talking about doses that are considerably higher than what you actually have prescribed for people, in full disclosure of that too, right? So some of these doses are very high and they're prolonged. And
so you're talking about the SafeR supply prescribing.
Yeah.
No, I don't go as high as those do, but I do use it in the context of like opiate agonist treatment. I use it for pain when people are leaving a hospital. I'll sometimes use it short term as a tool for patient engagement and symptom relief. I think the reason that the doctors are very risk averse is that historically the governing bodies have not punished you for withholding something. So, for example, if somebody has alcohol withdrawal, you're going to get more in trouble for giving a benzodiazepine that could treat it, where the person drinks and passes away, versus if you just don't give anything and tell them to go to an emergency department.
Right.
So I don't know if that makes sense.
Yeah, no, it makes sense. It makes sense. And there are not just doctors that are prescribers too. There's nurse practitioners, and in BC there's also registered nurses that are prescribers. So, and not every governing body is as liberal minded as another one. So
that's
as I understand it,
and you don't know how it's going to play out. And also, with doctors, you can sometimes argue that you're an independent care provider, even though you're sort of not. You still have a regulating body and all that stuff. I think with nurse practitioners, you're really an employee of, and you report to your manager.
Typically, yeah.
And so anytime that the manager of the hospital says, hey, you can't do this, you shouldn't be doing this, you have to stop this, you have to discharge the patient, I think you have to sort of listen or you're at risk of losing your job, right? And so...
Yeah, definitely. It's complicated.
It's complicated, yeah.
All right, so this is the protest that...
Hundreds of people marching in Vancouver here on Hastings on Friday in support of the founders of the Drug User Liberation Front, also known as DULF, who were arrested last week after the Vancouver Police Department raided their office and homes.
We don't think that our friends should be arrested and charged just for trying to save lives.
For once, our community did not have to resort to the toxic drug supply created by these prohibitionist laws. For once, we were given the chance to live. And what did the police and the government do? They shut it down!
The rally began at Main and Hastings Street and ended at Victory Square and called for safe supply, as well as for charges not to be laid against the two founders, who were later released from custody, saying they're simply saving lives abandoned by the government in a toxic drug poisoning crisis.
Not just a daily opioid user like me with a habit. Anybody, just having a party on the weekend, anybody's vulnerable.
The rally comes days after the BC Coroner's Service urged the province to immediately pursue expanded access to SafeR supply, following the release of a report on toxic drug deaths that found many of them were largely preventable.
Every bit of ammo that any politician would need to justify the Compassion Club model of SafeR supply is in this report. 225,000 British Columbians who use drugs risk death at any time if no action is taken.
That was a panel that came together of medical experts, even a policing member, people who are really deep in the evidence. It is robust and it is scathing, frankly.
BC declared a public health emergency over the toxic drug crisis in 2016. Since then, the BC Coroner's Service says more than 13,000 people have died from unregulated toxic drugs.
You got to disobey unjust laws. History changes when we stand up.
In Vancouver, Monica Gould, City News.
So that was a video of a protest that was occurring, and it sounds like the voices there are very much against these two people being arrested and charged. It sounds like they were arrested but not charged. And one of the comments really stands out. They talked about this report that talks about how all the deaths were preventable if certain things were done. I personally would love to know how to prevent the deaths. Like, what are those steps to do on an individual level? If I could, I would be doing that on a daily basis, right? And so I'd love to see that report and go through it and see what. Unfortunately, I suspect it has these blanket statements that may not end up saving everyone's life.
Yeah, I mean,
I'll have to look at it.
This is tough. This is really tough stuff for, because this is something that, I don't think there's simple answers. And I think the voices on the fringes are, on both sides, are not helpful. Like when the politician's saying you gave the money to murderers, well, these people aren't murderers. They're just trying to help people, for gosh sakes. They're not trying to hurt anybody. So nobody here is trying to hurt anyone on either side. But I suspect what they're saying, and I'll just cut right through it, where they say those lives could have been saved if it was a safer supply. Okay, but what? Again, I know I said it earlier in the same episode, but they're looking for fentanyl. I know this is not a convenient part of the discussion, but a lot of our patients are actually looking for fentanyl.
I finally get what you're saying with all this. I can't believe it took me this long. So yeah, there's a group in BC. They've gotten funding from SUAP, so a government agency through Health Canada. I don't know if it's like 6 million, 5 million, what it is. And they're literally developing patches, fentanyl, stuff people can inject because people want fentanyl. People don't want hydromorphone. People don't want this safer supply stuff that they're doing. And sure, if you have predictable cocaine, methamphetamine, heroin, great. People want fentanyl, and sometimes people want the fentanyl that has those adulterants in it because the high is different, it's intense, and it lasts longer. So I can't believe we've been chatting here now for 30 minutes, and I didn't realize that you're upset by this safer supply thing because they're advocating for something that's not going to help the people that want fentanyl.
Correct. Yeah.
Yeah.
I mean,
and that's what they're fighting for. They're fighting so hard for this, but it's not enough for those that want fentanyl.
Well, that's right. It's not. I mean, so only in Toronto now we do offer fentanyl, right? So we offer fentanyl at the
I didn't know that.
At the IOT program. Sufentanil is offered at the IOT.
Okay.
It's 3 injections a day. But yeah, Sufentanil was something they just started to offer. But the patch program is wonderful, but someone who's looking for that high is not wanting, is not going to want a transdermal patch that takes.
No. Once you have the transdermal patch, there's so many ways to use it, not like a patch.
No, there isn't. Not in those programs, because the program I believe that they're advocating is for the patch exchange program, which is for an unadulterated patch to come back.
Well, I'm not going to go over the different ways, but there's so many ways you can play with the patch the way it is.
Yeah, you can smoke it. You can do all kinds of things with it. But you have the patch program, as I understand it, that's being advocated for, which is a diversion, which is to remove the diversion, is you need to return the unadulterated patch at the end of those 3 days to get a new patch.
So if there's anything that suggests
if it's cut, sliced, smoked,
interesting.
Then it's not.
So I finally get it. I can't believe that we've chatted for so long, right? It's just because with the safer supply, I'm like, I don't know. I can't believe I didn't realize that what you're saying is that there's a lot of people that actually want fentanyl. That's what they look for. That's the high that they need. And here we are advocating for all this safer supply that's not even the drug they're looking for.
Right.
And we're increasing access to everybody. Right. Everybody of these drugs for this subset of people that are dying.
Yeah.
Some people do say that, maybe if they had hydromorphone, they wouldn't go to fentanyl. But I don't know if that's true.
Oh, they may not. If they had hydromorph, they may not go to fentanyl. Absolutely.
You think that's true?
I think that's true. But if they haven't gone to fentanyl, if they're not already there, I've not met anyone. I just personally haven't met any patient that I've supported that's gone from fentanyl to hydromorph.
Oh, but that's what they say in all these CMAJ, like these publications, safer supply, like, I don't use fentanyl anymore, I just use hydromorphone and my life is better. You just haven't met these people.
I have not met these people. I can't think of, have you met these people? Have you met any person that said that to you firsthand? And we've both been doing this. That's all we do every day.
No, but I don't have a high number of safer supply people in my practice.
You have a high number of patients that use substances and opiates. Have you met a patient without disclosing anything?
No, I have a couple that say
they've gone from fentanyl to hydromorph.
Well, no. They've gone from fentanyl to methadone to the safer supply. And
okay, that's fine. That's fine. I can see that happening.
But not directly from fentanyl to...
Right.
Well, actually, no, because when they say,
well, that's an interesting path, the one you just mentioned too. So they went from fentanyl to hydromorph, and then someone switched them to safer supply.
Yeah, methadone was in between. But I don't know. My point is, I
I haven't met the person. I'm not saying they don't exist. There may be hundreds of them, and maybe they'll all go into our chat and tell us.
Well, no, but in BC, I think the reason that they're going for the fentanyl is because there's a feeling among clinicians that giving hydromorphone is insufficient for these patients.
Absolutely. I mean, that's true. It's if they're on fentanyl, hydromorph is not sufficient. I mean, who's going to argue with that? No,
I mean, their quality of life does improve dramatically, right? Like, so say you get like 30 pills a day, they're about $2 a pill. Mm-hmm. That's like $120 a day. That's $3,000 a month in addition to your ODSP. Like, these people's lives are going to improve, with the
what about
the program?
And I know now I've just become this like wet blanket of conservatism now for some reason in this conversation. But so, and what about the people they sell those pills to? In your scenario there of this,
well, what the advocates would say that even if it is being diverted, at least it's not fentanyl that's being diverted. Like, isn't that what they say, or do they say there's no diversion? Or they say it's just not a real issue. That's what we're told, right?
Some people say it's not a real issue because at least they know those people are getting good drugs
or predictable drugs.
Predictable drugs.
Wording language is tough, eh?
Yeah, language is really tough, and
really tough.
I'm supposed to be the harm reduction guy at this table, and now I've come out as this, person that I don't almost recognize in a lot of times. But I think I'm sorry, some of this common sense stuff is just, I had a lot of different thoughts before I actually got into this work, and I actually see the people and hear the stories, and then have the people, have the young people come into places that I've worked that are new to substance use, that are using these substances, that are using these SafeR supply drugs. And it terrifies me.
No, but isn't this what like Health Canada and SUEP decided was okay? Didn't they decide that we have to save these fentanyl lives? Let's fund these SafeR supply programs, and let's not evaluate from a public health perspective what the diversion actually is. Like they could have set their evaluation framework to, like, for example, there was a paper published that talked about overdose deaths in adolescents, right? In the emerge, and they're going up, right? And can't you take 20 of those people and find out what was your pathway to addiction? Like, wasn't it? Can't you go to a high school and interview like 50 people but no one's doing these studies, no one's funding these studies. I think society's just decided that we have to stop these fentanyl overdose deaths. Let's use SafeR supply and see if it works, and let's not evaluate what's going on around these people that are getting it, because there's no good evaluation framework right now to look at diversion at all. Like, no one's even looking for it, right? It's
no, don't ask a question you don't want to hear the answer to.
There's not a single study that's looking at that. Like, outside of self-report from the people who receive, they're not asking the pharmacies where they're dispensed, or dealing is happening outside. They're not going to high school to say, what's your access like? When you go to a party, what are the drugs that are available? What are the access to there? I just think like it's... And I brought this up with a couple of researchers, like, I don't know how long ago it was, maybe it was several months ago. And I just said, look, I'm seeing young kids that are getting addicted to fentanyl faster than ever imagined. Usually hydromorphone is the intermediary. I'm just wondering, like, what's going on here? Is there a way to look at it? And the responses I got were like, well, how do you know it's SafeR supply? How do you know it wasn't pain meds that were diverted? How do you know if they had more SafeR supply, they wouldn't have gone to fentanyl in the first place? And it's one of those things where the only way that I've been able to sit with the SafeR supply, people that are from marginalized populations getting 30 tablets a day, where some of them are being diverted, is that society is okay with the diversion and society is okay with the harm, because these are government-funded programs.
Sure.
Like, and the government-funded researchers aren't asking those questions, right? So it's just like, if there's something like MAID, right? We're pro-MAID for some people. We don't think it should be like, you call a phone number and then you die within a day, right? Like, we don't think it should be that. But society's decided that MAID is important, even if it's because you don't have proper housing.
Right.
Like, you see that in the news all the time. I don't agree with that. But if society decides that's the case, right? Like, how can I stop that?
Well, I mean, all we're doing here is sharing our opinions and sharing our experiences, and hopefully trying to bring some light from those experiences so people can get a better understanding. And I don't care if the government says it, if you say it, if someone's saying it to me and if it doesn't ring true to my lived experience and my clinical work that I do, then I think we have an obligation to say, hey, you know what, this is a little bit different experience for us. Maybe other people are having this experience or that experience, but let's look at the results.
I just don't think we can expect politicians or people that have some kind of conscious or unconscious investment in the goals when we were at CSEM, we saw a talk from the Vancouver Island. I don't know what she was, public health or
she's medical officer health. I think.
So
for
all
Vancouver
of her
Island.
points sounded like political talking points, and there wasn't that curiosity around where does this data come from.
Yeah.
Right? Like she would say, this was certainty, that was certainty, that was certainty.
Yeah.
But if you start to unpack where that data comes from, so there's an article in the Globe and Mail recently, like a few days back, it was retweeted by a couple of people. At least they had the other talking points.
Yeah.
So they said, the BC coroner's office says opiate use disorders have not increased.
Yeah.
And these are what people say are the limitations of that data. And they're like, and they say this is not happening, and these are limitations. At least it was like listed, right? With when that public health official was speaking, I mean, obviously she cares, want people to die. She was one of the first people that's in a position of public health that says it was public health policies around shutting down the world with COVID that contributed to all these deaths with addiction, right? Usually you don't see people in the government say that, right? So she's coming from a great place, and there was all these talking points, and the end goal from her end was a regulated drug supply. That's where she was going towards. And from my own bias, is that I don't want to be prescribing drugs that are not helping the person in front of me, and I don't want to be prescribing drugs that have the risk of being diverted and kill someone else. I've had enough patients die from diverted methadone.
Yeah, what if Health Canada tells you
drugs.
that's what you should be doing?
Well, then I'll end up being a psychotherapist.
Okay.
Then I'm going to move to psychotherapy, and I'll put away my prescription pad. Just like with the MAID thing, I'm not going to be the one that's injecting people or putting them into these gas chambers or whatever it is. But at the same time, if society decides this is the medical care required, it's not my place as a regulated healthcare professional to prevent it from happening. And in this day and age, if you voice an opinion that goes against whatever society has decided, you're at risk for losing your license, not being able to practice, being attacked on Twitter, all that kind of stuff. And I'm not strong enough to face that barrage of comments and statements.
Well, I just think we should try to find a middle ground to this, right? I think that there are so many people that care so much on both sides of this argument that I think we need to really try to find the common sense approaches on both sides, right? And try to, maybe this murderer talk is a little much, and this, everybody should have every drug they want at any age they want, as much as they want, and this right to enduring euphoria is a human right. Well, you know what? I think that's a little you know, and I work with them every day in our own emergency room, and
we're all trying. We're all trying,
and it's just a matter of getting that knowledge out there.
I hope for that middle ground, you know. But I think people that are like deeply in the trenches, you know, they've had people that have died from an unregulated drug supply. They've had people that have been saved from SafeR supply. They've had people that are harmed from SafeR supply. They've had who knows which permutation combination. Yeah. It's going to be very hard to get them to the table, because the second they see somebody talking about the harms of a program that they truly believe in, they're going to have such disgust for that person. You can't even have a dialogue. You can't even find that message.
I'm aware.
Yeah, and so I mean, I hope there's a middle ground.
I'm personally, viscerally aware.
Yeah,
and I'm wearing it now. And but I believe in what I'm saying. I'm trying to have conversations with people.
I've seen you,
and you know, as best that I can, to be open to hearing what people are saying, and you know, it's and I'm going to keep trying.
No, so. It was tough. It was tough. I think the other day because we chat a lot here and there just about this podcast and about some other stuff too, and just the comment of the ostrich, you know, for me, and you know, just like, you know, some problem comes up, I put my head in the sand, and I do and I don't, and it's I'm not strong enough to put my voice out there in a way where it could damage my livelihood, the family, like lose my job, things like that. I'd rather not be in this arena, but I want these spaces to exist, right, where people can talk about it, right?
Yeah.
That's why you see me at this, whatever, the conference committee, at these discussions, asking for these different things that are there, because I think we need a space where these dialogues can occur. And even when somebody speaks and they say something that half the room gasps and gets very upset at, I'd rather there was something there to figure out, is there some truth in that, and how can we use it in a constructive way? Because I don't know, man.
So I think this is going to be one of those to be continued conversations. What do you think?
I think so, and even if I don't know how we're going to make this into something listenable, but at least we're speaking.
We'll leave that to our editing team.
Who's
our editing team?
Yeah, and if anything comes up, you just want to throw it out there, see what happens. Out of the 30 viewers, see what the comments come up. You know,
our short just had 1,600 views, and you're calling us 30 viewers. There you go.
1,600?
1,600 so far.
Was that the recent one that?
The one this morning, yeah.
Oh, you published that?
Yeah.
1,600?
Yeah.
What?
There you go.
People are hearing your voice. Yeah.
There you go.
And it was correcting news misinformation, right? Like,
yes.
You know, like, and because, you know, people see that propaganda and they don't go deeper. Right.
Okay, thank you.
Thank you.
Thanks for watching. If you like what you saw, please feel free to like and subscribe. That way you'll get notified when we come out with new content. We try to come out with new content about every week or so. So anyway, thanks again and see you soon.